So I'll be looking at three broad domains in terms of ventilatory management, ventilation adjuncts, and pharmacotherapy. So ARDS was first described in 1967 by Ashbaugh and colleagues. And this was about 50 years ago. And 50 years later, where we are now, the description is exactly the same, whereby it's characterized by acute onset of hypoxemia, which is refractory to supplemental oxygen treatment, decreased lung compliance, the lung is tight, and diffuse pulmonary infiltrates. In 1967, it was described based on chest radiograph, and even now, we are actually basing our definition based on chest radiograph. So the ARDS has these typical pathological findings in that there's a diffuse alveolar damage, the formation of hyaline membranes, hemorrhages, edema, as well as atelectasis. And criteria for ARDS. Initially in 1967, it was just a description. But in terms of defining criteria, it was first set in place with a Murray Lung Injury Score established in 1988, and also upon first American-European consensus definition of ARDS. And this definition has been updated, the last updated in 2012, which is almost 20 years, almost 10 years ago. And the criteria was based on what is called as the Berlin criteria, which means any symptoms that begins within 1 week of insult, meaning that this is something that just happened within the week, or now, or worsening symptoms within last 1 week, presenting with bilateral opacities on chest imaging. And the key word is that bilateral opacity, the both sides of the lungs affected, with the PF ratio of 300 or less, while being on a PIP of 5 centimeter water. So this is usually a definition that takes into account of ventilated patients, because PIP is an element here which has to be set at least 5 centimeter water. And with the provision that all these changes are not fully attributed to cardiac failure or volume overload, because cardiac failure and volume overload could also cause the presentation of bilateral lung haziness. So when you have this bilateral lung haziness not being attributed by either fluid overload or CCF, and you have a hypoxemia, and when you hook it to the ventilator with a PIP of at least 5 centimeter applied, and the PF ratio that you calculate is 300 or less, then you got ARDS established. And this mild, moderate, severe further can be categorized further based on the PF ratio of from the 300, 200, and below 100, respectively, for mild, moderate, and severe. Now we go into ventilatory management for ARDS, and this is the key target in terms of pressure and volume limitation. So the first ARDS network study, which was almost 20 years ago, it was in the year of 2000, recommended lung protective ventilation, because from the study it was seen that if you set the tidal volume too high, you will cause damage to the alveoli or ventilator-induced lung injury. The recommendation include limiting the plateau pressure as well as having a lower tidal volume set to 6 mils per kilogram. And all these were based on 2 decades of laboratory work. Remember, this ARDS had been in place since 50 years ago. So for decades, based on the work that they looked at, that brought to the birth of the first ARDS network study that brought about this recommendation. And if you apply the lung protective ventilation, you would have an outcome of improved survival, shortened duration of mechanical ventilation, attenuated or less systemic inflammation, because from following ARDS, there is a systemic inflammation in place with the inflammatory neurochemicals produced more in the system, as well as reduced extrapulmonary organ failure. So this is where we are 20 years later from the first established recommendation by ARDS network study. The volume and pressure limitation strategies remain in this lung protective ventilation. There is this targeting of tidal volume of 6 mL per kilogram of the predicted body weight, which is recommended, and the adjustments of the this tidal volume between 4 to 8 mL per kilogram as while keeping the plateau pressure below 30 centimeter water. And in the practice also currently, there is we allow hypercapnia, or what we call permissive hypercapnia, because the hypercapnia won't kill the patient, but the hypoxia will. And also there's an aim to minimize dysynchrony whenever patient has a high respiratory drive, because if you see when patient breathes with a large tidal volume, that also could cause alveoli injury, or what we call a patient-induced lung injury. So this was a recommendation, a paper that was published in 2019 by Papazian. And in this paper, again, if you look at what was recommended almost 20 years ago, was the target of the tidal volume of 6 mL per kilogram, with the target of P plateau of less than 30 centimeter water, and also with the PIP of more than 5 centimeter water, and reassessment. This is the basic practice in handling or managing the ventilator for ARDS. So it all starts with this first setting of the ARDS, the ventilator for the ARDS, with a target tidal volume of 6 mL per kilogram, and also systematic screening for ARDS diagnosis criteria. With all this done, confirmed ARDS, you would set it at 6 mL per kilo of the tidal volume, with a plateau pressure target of less than 30 centimeter water. This becomes a magic figure, never to cross 30 centimeter water. And having the PIP always above 5 centimeter water, we want the PIP to be higher, and check for hypercapnia as we do this. And when patient has a PF ratio calculated to be less than 200, a higher level of PIP should be employed to improve the oxygenation. And having done that, if the PF ratio is less than 150, then there is a role of a neuromuscular blocking agent being instituted, as well as a prone positioning. And when the PF ratio is so low, less than 80, then the veno-venous Ecmo can be considered. So if you look at this, which was prescribed by Papazian, they have put in what they recommended, and these were all that was recommended. In fact, for the neuromuscular blocking blockers, it was it was recommended to use the infusion with the early initiation within the first 48 hours if you have very poor PF ratio. Okay, now this is some of the evolving standards in terms of the ventilator setting, because there is now a recognition of the heterogeneity of the ARDS, meaning that there are no two ARDS which are identical, and individualized approach for the volume and the pressure that is set maybe the ones that would make the treatment more accurate. And there's now more and more importance being placed in terms of driving pressure, which is given by the plateau pressure minus the PEEP, being a critical mediator for improved survival in ARDS, based on meta-analysis by Amato since 2015. There's also a focus on this driving pressure, which is superior to a simple tidal volume. Remember, the initial recommendation did not touch on the driving pressure, but now we're looking at this driving pressure, and it is more accurate as it is a measure of tidal volume corrected for respiratory system compliance. So there's also other things which are evolving in the literature. For example, Gattinoni had introduced the concept of mechanical power for a ventilator, and the high-end ventilator now could calculate the mechanical power, and this mechanical power is being estimated using this information in terms. They take into account the tidal volume, the respiratory rate, the peak pressure, as well as the driving pressure. And all this, the mechanical power is associated with mortality. So this becomes one of the parameters that can be a target so that it could be kept low. So there is also some other evolving standards. In this paper, there is an analysis of a registry of 13,000 patients with a hypoxemic respiratory failure, or in other words, ARDS, and it was found that there was higher mortality with higher driving pressure and higher mechanical power, as well as baseline hypoxemia. So it's becoming established in terms of study. The individual titration using higher PEEPs in patients is becoming also an evolving standard. And the outcome can be worse if the ventilatory strategy is not aligned with the lung morphology properly. And usually, to get the correct PEEP, the pressure volume waveform can be utilized as one of the tools, whereby if the lower inflection point is detected, then usually between 2 to 3 centimeter above, the PEEP is set between 2 to 3 centimeter above of that lower inflection point. And this would keep the lung open when the correct PEEP is put there. And the recruitment often occurs throughout inspiration. So there are other things which are coming into place, the emerging methods to help guide the accurate PEEP titration. Usually the PEEP is started using the PEEP FiO2 table for a start. And once that is established as a start, looking at the subsequent ABG, then the PEEP can be titrated, whether upwards or downwards, to achieve the lowest possible driving pressure. There is this thing called the recruitment inflation ratio, which could tell how many new lung units are recruited versus existing lung units stretched for a given change in PEEP, and can be calculated with the online tools. There's a website that you could go, and if the value is more than 0.5, then it would indicate a higher amount of recruited lung. So it's a bit technical, and you have to calculate all these values and put in, and it will give you, and when you press calculate, it will give you the value. There are other things which is evolving in standards. Some people have been using this as a standard with the use of esophageal pressure. Esophageal pressure is a pressure that you get. You put in the balloon through the esophagus into the stomach, and then you could inflate the esophageal balloon. And the value that you get, the pressure that you get when you inflate the balloon will actually give you an indirect measurement of the pressure of the pleura, or a pleural pressure. This pleural pressure is one of the components to calculate the transpulmonary pressure. And this transpulmonary pressure is the one that you need to keep the lung not in atelectatic state, to keep the lung open and recruited. So you need to have that because it's calculated from a difference between alveolar pressure, which is given by the P plateau, and the difference given with the pleural pressure given by the esophageal balloon. And the difference is that is keep to maintain the transpulmonary pressure around 0, and some would keep it between 0 to 5. So this is one way to get a more accurate PIP to set for patient in ARDS, especially patients which are difficult. For example, obese patients and all that, you're still not getting good oxygenation. So this can help you to guide what exact PIP that could be placed so that you could put it higher but not too high so as not to pop the lung, but high enough that it would recruit the alveoli. And multi-center studies then compared with the higher PIP FiO2 table, because when you look at the FiO2, the ARDS net table, there are two tables. One employs a lower PIP, the other one employs a higher PIP. From multi-center study, when they compare applying the higher and lower PIP, there were similar levels of PIP between the two groups, but no differences in clinical outcomes. The other thing is the coming into place is the use of electrical impedance tomography that could assess the lung morphology and guide ventilatory strategy. And this is non-invasive, it's also radiation-free, that the PIP could be titrated and you could limit the over-distension by the assessment of the aeration loss and over-distension. But the availability of this machine is still limited, and there's still no large randomized clinical studies. Okay, now we look at the Pip and Lung recruitment in more detail. So Pip improves oxygenation. Pip is useful to recruit atelectatic lung, which is a problem in ARDS patients. And the problem is that the level of Pip is debatable. Which Pip that you want to set or to put in accurately. Sutter and Fairley described that the best PIP would maximize oxygen delivery and also would maximize the compliance, and it is inversely proportional to the baseline functional residual capacity, or in other words, the size of the baby lung. Baby lung is what we term an atelectatic ARDS lungs, whereby the lungs have become shrunken because of the collapse of the alveoli. So in terms of two common approaches in setting the ARDS, number one is to use the highest PIP that could maintain the plateau pressure below 30 centimeter water. And this was used in the Express trial. And to target oxygen saturation via the use of the PIP FiO2 table and assigns the higher level of PIP at higher required FiO2. So you could use this is the table that I meant. You have a low PIP or a high PIP that you could choose. So there are trials in terms of, one trial is called the alveoli trial, the other one is called the LOS trial. So from the trial, the PIP FiO2 table, which was used in original ARDS network trial of low tidal volume, was compared to modified table assigning higher PIP, this low and high. Individually, each of these studies showed there's no difference in mortality whether you use a low PIP or a high PIP. However, when a meta-analysis was performed, combining the data from these two studies, it was found that the higher PIP lowered the mortality for patients who had a PF ratio of less than 200. But if you use it for those with those having a PF ratio between 200 and 300, there would be an increased mortality. In other words, it is from these findings, it is suggested that a higher PIP is reserved for those having a PF ratio less than 200. So there are some evolving standards in terms of the individualization of ARDS patient. because ARDS patients have subphenotypes, or in other words, the type differs. One has a higher inflammatory profile, the ones that this patient tend to produce more inflammatory chemicals, respond more, and the other one less. So mortality effects depend on the inflammatory profile, and oxygenation response to PIP increase. So a higher PIP is tolerated and dependent upon severity of the lung injury, the impact on pulmonary circulation, as well as cardiovascular reserve. So like I said before, that there are no two people having the same character of the lungs. So this becomes an issue whether they are of the first phenotype or the other phenotype. Yeah, so now there is this thing about when for atelectatic lungs in ARDS, the lungs collapse, and you want to recruit the collapsed lungs. And these are the recruitment maneuvers that are available currently. The first one is to use sustained inflation, whereby you employ a high PIP and maintain it for a determined set of number of seconds, and then you release it, and that's it. It's just one-time thing. The other one is the intermittent size, whereby when you set the ventilator, you could employ a sigh, meaning that after, for example, 100 ventilations, the machine would deliver a 50% higher tidal volume in order to recruit the lungs. And this would be done with our machine. And the other one is stepwise increases, whereby from the initial set PIP, higher PIP is set every 3 to 4 breaths until the targeted PIP, for example, until 25 centimeter water, and then you come back down. So, and sometimes it was also done in combination with higher PIP. And then currently, what has been recommended from ARDST study is that the routine use of staircase recruitment or the stepwise increases is not recommended. And there was also in the past the use of HFOV, the oscillatory ventilation, high flow oscillatory ventilation, is also not recommended. In fact, the findings showed suggestive of potential harm. So what is currently used is either the sustained inflation or intermittent size. Okay, now we go in terms of ARDS patients, in terms of the spontaneous breathing of ARDS patients, because when we look at patients in when we set the ventilator, usually we set the tidal volume that we control by the machine, and we could set it at a lower tidal volume. But there are patients who are having a high respiratory drive that on their own, they would breathe in a way that the tidal volume is much, much higher than what we try to limit. So this is what we want to look at. So the thing about spontaneous breathing is that apart from oxygenation, when we allow spontaneous breathing, we would minimize diaphragm or respiratory muscle atrophy, because the respiratory muscle keeps on working. For example, when on SIMV mode, we still allow part from the machine delivered ventilation, but patient's own breathing. Or if patient has a good respiratory drive, even on pressure support volume mode, so they are breathing on their own. So partially assisted breathing is commonly employed, or this either the CMV or SIMV mode in moderate to severe ARDS patients, and this is associated with improved outcome for weaning purposes later. Spontaneous breathing with or without assistance, however, may lead to further lung injury, or what we call patient self-inflicted lung injury, or PCLI, because we allow patient to breathe with a high tidal volume. For early phase, in the early phase of ARDS, augmented spontaneous breathing may induce patient ventilator dysynchrony, and high tidal volumes that is generated could promote lung injury, ending in PCD. So that is the problem with spontaneous breathing. This is some of the findings in some of the papers, like again here, when they look at patient having spontaneous effort and those who were paralyzed, that there's better oxygenation when patients are paralyzed. And also when they look at survival too by Papazian, with paralysis, there's also a better survival. Now, the other thing about as an evolving standard is the use of airway pressure release ventilation, or APRV. So what is APRV? We're used with the ventilator modes in terms of the CMV or SIMV, PSV, but we hardly use this mode of APRV. It is an evolving standard. So what it is, it means that, you know, we use with, for example, BiPAP, right? BiPAP, CPAP, BiPAP. Okay, CPAP, they just give you one level of PEEP that keeps the alveoli pressure open, open following the pressure. But when you apply BiPAP, you have the PEEP as the baseline, but you apply another PEEP when patient breathes, and then that helps to support the patient breathing when patient inspires. Yeah? So APRV is a bit like a modification of BiPAP, whereby you are allowed to breathe on your own. That's why this comes under the topic of spontaneous breathing, because APRV is actually a mode that allows patient to breathe spontaneously throughout. And they can do that during a lower PEEP, they breathe in and out, and also during the higher PEEP, in and out. What's the difference is that in this case, we give 2 levels of PEEP, but we also control the time that we deliver the PEEP, the higher PEEP, and the time that we allow the lower PEEP. Because of this, the time that we allow for a higher PEEP becomes or mimics an inspiration for the patient, whereby there is a higher oxygen delivered with the higher PEEP. And the time that we allow for the lower PEEP would be the time that becomes like an expiration for the patient. So by modifying, determining, controlling the time that we give for the higher PEEP and the time that we give for the lower PEEP, despite patient is breathing spontaneously throughout, we're able to set a higher IE ratio. It can be like something like 5:1, 7:1, even 9:1 for such patient, and at the same time they're still breathing spontaneously. So it was been found that from this RCT that the APRV improved physiological and clinical outcome. And there's already a meta-analysis of 14 studies, which was published this year, that showed improvements in oxygenation with APRV, but there was no difference in terms of ICU stay and mortality. One pediatric ARDS trial was stopped early because it was observed that there was increased mortality in the APRV arm. So this APRV is reserved for patients in whom we just simply fail to get good oxygenation. And the standard is still evolving because of, although it does improve oxygenation, but the outcome is not clearly differentiated with the utilization of the APRV. In fact, a potential worse outcome was seen in the pediatric population. So now we move on in terms of spontaneous breathing in RDS. What about the use of non-invasive ventilation? So there was this Florali study. Florali study is looking much at the non-invasive ventilation. A 3-arm trial in the Florali study suggested that when they look at the high-flow nasal cannula, it was better than face mask NIV in preventing intubation and reducing mortality in patients with a severe hypoxemia. There was a study by Patel in 2016 we showed that NIV delivered by helmet CPAP was better than face masks for patients with early ARDS and reduce the need for intubation and improve mortality. So what it tells us, it suggests that there is a role of, if during early ARDS, for you to use non-invasive ventilator in the form of either high flow nasal cannula or CPAP, but not so much. I mean, it's better than using the face mask NIV. Rockwork in 2019, who carried out a systematic review on high flow nasal cannula, shown the reduced need for intubation and invasive ventilation. And in 2020, a network meta-analysis showed that both nasal cannula and helmet and IV lowered mortality compared with standard oxygen therapy in acute hypoxemic respiratory failure. So if this is to be considered, if NIV is to be considered for ARDS, then it is either the high flow nasal cannula or the helmet CPAP that could be employed. Okay, now we've lived in the age of COVID-19. So we want to look at in terms of ARDS management for COVID-19. Yeah? So for this, we look at the ARDS due to COVID-19 often looks like and behaves like quite similarly with ARDS from other causes. And currently, the ventilatory approach for COVID-19 patients are somewhat the same, just like those having ARDS from non-COVID patients. So this is one of the recommendation by Comporono in that he employed by using this escalation stepwise approach. He starts off by when he intubate. Interestingly, he uses 8 mils per kilo rather than 6 mils per kilo, a bit higher. And then what he does after he starts, this is the starting starting tidal volume. He looked at the driving pressure. If it is less than 15 centimeter water, he would maintain it at 8 mils per kilo. If patient is having driving pressure more than 15 centimeter water, then only you will reduce it to 6 mils per kilo predicted body weight. And after that, you would be looking whether the SpO2 is less than 90%, despite the FiO2 more than 0.7. If it is still low, despite this high FiO2, he would institute neuromuscular blockade. And he would increase the PIP in 2 centimeter steps up to 15 centimeter water. So his approach is to paralyze the patient and to increase the PIP to as high as 15 centimeter water with in the step of 2 centimeter water each time. And if that still fails, then he checked the compliance, calculated. This can be calculated either manually or by the machine. If it is 40 centimeter mils or more, okay, we look down, then he would employ a prone positioning. But if it is not, meaning is the compliance all right, then he would approach by recruiting maneuver. And he would use 40 centimeter water at up to 15 seconds in recruiting the lungs. So there is this ARDS-like phenotype or COVID-19 pneumonitis. Phenotype H, which show a high elastance, PIP responsive, prone responsive, and also there's a phenotype L with a low elastance, prone responsive, and they would consider inhalational nitric oxide. So among ARDS also of COVID-19, these phenotypes has been suggested. So if all fail, there's hypoxemia regardless of the prone positioning or even Aprv. He even utilize Aprv for 6 hours or more then the Ecmo would be considered. So just take a look in terms of the prone positioning. So this is an approach which is recommended if the PF ratio is less than 150. And it was shown that it improved gas exchange, improved survival, does not depend on improved oxygenation, decrease ventilator-induced lung injury, and it results in more uniform distribution of volume and distending forces across the lung. So the atelectatic lung alveoli tend to open up more. From the baby lung, it becomes a better baby lung, meaning more areas employed when you change the position. So the current recommendation when prone positioning is instituted is to have a long daily sessions of 16 hours a day when you start in moderate to severe ARDS. And the first line therapy in moderately severe and severe ARDS and generally be continued, and this is continued until the PF ratio is above 150. So you start when it is less than 150, you maintain it in that position until that you cross becomes more than 150, then you can put patient in supine position again. So this is example of how they turn patients into prone position. You need 5 people to control the airway so that the ET tube is not dislodged, and then you get the patient in this position. So now there's this evolving standard with the ARDS for COVID-19. For ARDS, a prolonged prone positioning of time. They found when they compare it between 36 hours as opposed to 16 hours of the normal practice of prone positioning, it was safe. It was found to be safe and has a pronounced impact on oxygenation. So in fact, for awake spontaneous breathing COVID-19, meaning this patient, they are breathing spontaneously, and they were asked to change their position to prone position. It was described that most patients responded with increase in arterial oxygenation in prone position. However, the efficacy of this prone positioning in spontaneously ventilated patient is still experimental and limited to case series. Okay, now we move on to the usage of neuromuscular blockade. Yeah, so the current standard is that when there is a high respiratory drive and spontaneous respiratory, it can cause severe patient ventilator desynchrony, and this can increase lung injury. There's a multi-center RCT with 48 hours of paralytic infusion in moderate to severe ARDS. This was all done by Papazian. We showed improved survival and increased time of the ventilator. I think I've showed this graph before. He used this infusion, but there is a concern in terms of long-term effects on muscle strength and need for concomitant deep sedation. You're subjecting patient to this. Basically, you're making patient not exercising the respiratory muscle. So there's concern in that sense. So there was a trial that was conducted called the ROSE trial, and it showed no difference in mortality between groups of paralytic infusion and deep sedation. So this is contrary to what Papazian discovered. And for that, in fact, this study, they stopped the study earlier. And the blocking agents should not be used routinely in all patients with moderately to severe ARDS. It has to be selective. And who can be considered for the neuromuscular blockage infusion are those patients having severe patient ventilator asynchrony, those having markedly increased respiratory drive, which we fear would end up in PCL, those having persistent high drive pressure, and those which is difficult to oxygenate or ventilate. So, okay, now there's this talk about the inhaled nitric oxide. Currently, in fact, HKL does have nitric oxide in the ICU. For inhaled nitric oxide, it would result in selective vasodilation of the pulmonary circulation of ventilated regions. Yeah? It reduces right to left shunting and improve oxygenation. But no studies had demonstrated beneficial effects of inhalational nitric oxide on the clinical outcomes of ARDS patients despite improved oxygenation. So currently it's not recommended for routine use of RNO, but it is reserved when they are at their end in trying hard to improve oxygenation, but it's not working. Okay, now we look for Ecmo now, extracorporeal lung support. So basically this is in this approach of venous extracorporeal membrane oxygenation with the Ecmo, what we do is actually we draw the blood from the venous and then we put the unoxygenated blood from the vein and oxygenate it via machine and then put the blood back into the artery, into the circulation. So basically we have an artificial lung and we rest the lung of the patient. So this provides oxygenation, allow for reduction in terms of the intensity of the mechanical ventilation. We rest the lung and substantially reducing villi. And based on 2009 influenza pandemic patients, from observational studies, it was noted that there were beneficial effects of influenza A, H1N1 related ARDS. But when they look at this with other patients, not due to influenza patients subjected to ECMO, there were similar mortality rates. So it's hard to see. It doesn't show that it provides something better compared to the rest. Yeah? Now, there is this thing called Caesar trial, whereby there was a study that compared patients who were sent to an ECMO center and patients who were not sent to ECMO center, and they found that those sent to ECMO center, there was a significantly lower mortality rate or disability at 6 months. But there's a flaw in this study because those sent to the ECMO center also are not all underwent ECMO. So that makes this study difficult to conclude. There's another study called EOLIA RCT, whereby early ECMO was instituted for patients with a severe ARDS with a PF ratio less than 80. And the mortality was lower in the ECMO group, 35% versus 46% in the non-ECMO group, but it was not statistically significant. So it was concluded may have some benefit. And a meta-analysis that combined both the CESAR and EOLIA trials showed statistically significant mortality reduction. So some post-hoc analysis suggests that there's likely reduced mortality in patients with severe ARDS. Therefore, with these findings, ECMO is reserved for the patients in the after all had been exhausted and you still have a poor oxygenation. But we have to be selective, and based on EOLIA inclusion criteria, this ECMO should be reserved because 40% will still die. So it's reserved for those who are young, having reversible etiology, few comorbidities, and is employed in experienced ECMO centers. From the ELSO registry, which is the registry for all ECMO instituted for patients throughout the world, it was found that among COVID-19 patients, there was a 40% mortality rate, and this mortality rate is similar to patients receiving ECMO from other causes. So it's expensive thing, but you will get out of 10, 4 will still die, 6 will survive. So CESAR and EOLIA showed that ECMO is most beneficial in patients with only 1 or 2 organ failures. More than that, it's not beneficial, and patient will still end up dead. Okay, and lastly, we look at the pharmacotherapy in terms of steroids. So there was a role of corticosteroids in early ARDS, but it was controversial. From the ARDS network trial, there was no difference overall. And in fact, a suggestion of harm if steroids were started late. Late means 2 weeks after the ARDS onset. From older meta-analysis also, there was decreased mortality, but there were mixed results. Some, significant, some not significant. So in the end, in terms of ARDS, we do not have a conclusive evidence to say that steroid helps to improve patients' outcome. There was a multi-center RCT among 277 patients, and it was shown that early administration of dexamethasone reduced the duration of mechanical ventilation and mortality. A meta-analysis, but not much. The population is not big enough. Conducted by Zaid, published this year, showed significant reduction in mortality with the use of corticosteroids. But again, the number of patients is not that many. It's suggestive of positive effect. Now, the thing about COVID-19, we also learn many things about COVID-19 from the ARDS suffered by COVID-19 patient. There's this recovery trial. This was published last year, that showed if you institute low-dose dexamethasone for 10 days, early, there is a reduced mortality in patients who require oxygen or respiratory support. A prospective meta-analysis of COVID-19, 1,700 patients from 12 countries, and when it is instituted early, compared to usual care or placebo, no steroid, there was a lower 28-day all-cause mortality. So there's a moderate degree of certainty at this point of time that corticosteroids may improve outcome in patients with COVID-19. So if you see COVID-19 confirmed for COVID-19 patients in our resource, we would recommend that you start the steroid early. If you have dexamethasone, it would be 20 milligram. If not, if it is hydrocort, is a bit higher, more than 100 milligram, 160 milligram. If it is prednisolone, 40 milligram. So this is given daily in a period of 10 days. So you can start without anybody saying or giving instruction. It will be beneficial at this point of time. But with these are among the population of COVID-19 patient. So for ARDS not caused by COVID-19 patient, the evidence, well, it's suggestive, but it's not conclusive, because the recovery trial, the meta-analysis are all upon population of those having COVID-19 patients. Okay, now we go to fluid management. It's just that we had, in terms of fluid management, the FACT trial in the past had shown improved lung function and more ventilator-free days with a conservative fluid strategy. And Grissom in 2015, in his paper also, when he employed conservative fluid strategy based on CVP and urine output, once a patient stabilized from vasopressor, showed similar outcome in FACT trial, whereby if you conserve fluid, there will be improved lung function, and seems to be patient would be less dependent on the ventilator subsequently. Now, patients with ARDS who no longer have shock, this is subsequent after stabilization, should have their overall fluid balance reduced in a matter of between 500 to 1,000 daily by the usage of diuretics and reduce intravenous fluids until they are Iv Albumin. This is one of the suggestions, to use diuretics even. So this is from the finding of the FACT trial, which compared between liberal versus conservative fluid management, and it showed that conservative management group did better with that. Yeah? So with the current standards of from the secondary analysis of the FACT trial, there is a heterogeneity of treatment effect in terms of the mortality based on the baseline CVP levels. When they look at the data, those with the CVP 8 or less had significantly lower mortality when managed with conservative fluid strategy, but we hardly use CVP at our setting. So this is more in the ICU. So in any way, the study suggests avoidance of excess fluid administration is more valuable rather than diuresis. So I think in our practice, we are giving fluid just enough, just nice, when we employ looking at the echo, looking at the size of the heart chambers, looking at the IVC collapsibility, and not to give it more than it should, just to aim for euvolemia. So these are some of the evolving standards that there's also different effect for patients with hypo and hyperinflammatory phenotypes, and fluid restrictive strategy is more beneficial for those with hyperinflammatory group, and the opposite is true for the hypoinflammatory group. Okay, now there are some evolving standards utilizing many things being studied to see if they have any effect on ARDS in terms of surfactant, beta-2 adrenergic agonist, prostaglandin E1, activated protein C, antioxidants, omega-3, ketoconazole, recombinant human factor 7A, statins, interferon beta, and vitamin C, but none showed benefit. So, as for conclusion, sorry, talk ni jadi 1 jam juga. As a conclusion, the ARDS description is still similar since 50 years ago, and the current definition is based on the 8-year-old Berlin criteria. It may need revision because it lacks specificity. The ventilating ARDS still target protective lung with the same volume and pressure limit, but now with the emphasis of driving pressure. Driving pressure and mechanical power affects mortality. Esophageal pressure helps to attain more accurate PIP, and the higher PIP ARDS net table is recommended more for patients with VF ratio less than 200. Subphenotypes of ARDS affects mortality, and for recruitments, we only employ sustained inflation rather than stepwise ataupun staircase method. And paralysis is only for selected patients. For those having asynchrony, high respiratory drive, or high driving pressure, early steroids is beneficial for ARDS, and avoid excessive fluids. So with that, thank you.
Okay, thank you very much, Dr. Alza, for the very informative talk. Perhaps we could allow, if anyone have any question, is it okay, Dr. Alza?
Yeah, sure.
If, let's say, anyone have any question, you can type it in the chat box, or you can also on your mic and ask Dr. Alza directly. Okay, yeah, some of them was asking whether they can have the slides. So I think it was being shared before. So later, yeah.
Can, yep. I shared to Nafisa. You can ask from Nafisa.
All right, sure. All right.
I saw there's 157 people, so I'm glad that a lot of people joined in. Thank you so much.
Yeah, thank you very much.
Yeah, that's quite mouthful to take. Yeah, but I hope you all would benefit from some of this sharing today during this PKP.
Okay, there is one question from Raj, Dr. Alza.
Yeah. Okay, for the paralytic agent, the study that they use a trachurium. So based on that is tracheum based paralytic agent, and we also utilize tracheum sometimes when we have a desynchrony, but a lot of time is more of a bolus thing rather than infusion. But that is one of the consideration if we've tried everything else, because if you look at the Papazian, the recommendation is either prone and paralysis stands on the same category when the PF ratio is already less than 150. But to do prone positioning in ED also needs careful monitoring, closer monitoring, because you imagine the ETT tube, on the other side, to make sure that it doesn't get dislodged and all that. So, but instituting the paralysis is easier lah. But you can start with if you come to a point that it is so difficult with extreme desynchrony despite high sedation that you could try a bolus first and then consider the infusion. This can be discussed with the NSLA to have a common agreement to start with that. Okay, this the other confusion. How do we decide fluid is just nice in the event of hypotension? Okay, fluid is just nice when we have a window that we look at. In the past, people, one, you look clinically, kan? Clinically, one, for patient who's dehydrated, for that can be from the clinical assessment, looking at the mucus, looking at the capillary refill, those urine output, those are the mark of patient perfusion, where the patient's underperfused, not enough perfusion. But to make it more accurate, in the past people use CVP, but it has been shown that CVP is not accurate. If in patient had also used pulmonary artery catheter, but that's invasive. So that's pretty hard. But we now have echo, we now have ultrasound. One of the things to look at having a just nice fluid is looking via echo, whereby we look at the chamber. So hyperdynamic, the chambers are or kissing. You can see it's very small, and then this is again confirmed by IVC that you could see the size is small and the collapsibility is high. Those means that patient needs fluid, and if you want to be more accurate to see if patients responsive to fluid, you could use a passive leg raise test. It's like artificially giving between 250 mils to 500 mil of fluid without giving fluid, which means that you elevate the patient's back 45 degrees, and then you flatten the patient with both legs up and hold it for 90 seconds. And you measure the VTI from the echo. This is the left ventricular outflow tract VTI. That would give, if it increases by 10%, then you would know that this patient can get fluid some more. But if it doesn't increase, meaning patient have got enough fluid. So the other way to look at is also from the pulse oximetry waveform or arterial. If patient have invasive arterial blood pressure, that you could look at the arterial waveform. That if you look at it's not scatter, it's not like VT scatter, it's like VF. There's up, there's down, the ups. That means patient could still take in fluid. So in answering your question whether it's nice or not, you look at multiple parameters. In the even IVC alone, if you don't take into account other parameters like the volume chamber in the echo, it is not exactly accurate, because some patient may have underlying pathology ataupun morbidity like heart failure and all that, which can give an artificially high IVC. So there are multiple parameters that you look at, but I would say you could the ultrasound and the echo would be very helpful to determine that patient has a just nice fluid. So the other question, okay. How do we perform the sustained inflation strategy? Okay, there's a sustained inflation strategy. If you use the machine, whereby you would change the mode into apply a CPAP, and then with the CPAP you raise it to 40 centimeter water, and then you sustain it at that level for a good. Amato suggests 40 seconds, but the Comparano suggests 15 seconds. So in the past, people do, kalau tak berani, they do try 20 dulu, 20 centimeter water for 20 seconds, 30 centimeter for 30 seconds, and then 40 centimeter for 40 seconds. So there is a sustained inflation. Okay. Then explain on driving pressure. Okay, driving pressure is the difference between the P plateau and the P. It is the pressure that ensures that the lungs are open, that it stays like that. So you need to have a high to keep it below 15. Bukannya apa? It's just this is a more accurate way of taking into account the compliance. So that we do not damage the lung from a ventilator-induced lung injury. So we keep the driving pressure low. So if it is too high, with the compliance not so good and all, then it will damage the lung. Then the other question, COVID patients usually have concomitant due to their hypercoagulability, on how we should investigate is delayed to packed ICU. Yeah, you're right. There is a risk of hypercoagulability of ARDS. This is more ICU management. I wouldn't dare to immediately start with Clexane or Fonda at the point in ED without discussing it with the NS. At this point of time, what I'm advocating is just at least early DEXA. That would make a difference in terms of the mortality. Using IV albumin in terms of fluid replacement strategy. Okay, the role of IV albumin. There is a study called Albios and SAFE study, whereby they compared the use of albumin and crystalloids in resuscitation septic patient. And the outcome is that there's no difference. Albumin is very expensive, and I think it should be used targeted and sensibly. For example, patients with dengue with leakage, then there is something that you could consider using albumin. For patients having a low albumin less than 20, then you need to supplement the albumin for the fluid. But the rest will still utilize the same crystalloid. Okay, calculating tidal volume for obese patients. No, you still use the predicted body weight for obese patient. Adjusted body weight is more for drugs or fluids that you would employ. Okay, so that's all the questions I could read from the chat box.
Yeah, so I guess very, very good question from the audience. So they're really like into the topic. Thank you so much, Dr. Alza. So
Yep.
I guess that's all the question for now. So I'm gonna share
Yep.
with all of you. Thank you very much. Thank you, Dr. Alza. Thank you very